we've all been talking about exposure to antimicrobial agents. Which agents are the worst offenders? Which ones do we really need to be careful about? And in taking a history from somebody with diarrhea, which antibiotics would you ask about, for example?
Well, first of all, any antibiotic essentially can do this, can be associated with C. diff. And yes, there are high-risk antibiotics and low-risk antibiotics. The highest, as was mentioned, it would be the fluoroquinolones and the cephalosporins, and the lower risk would be the sulfa drugs and penicillin. And more than that, I would need an infectious disease person to help guide me through the exact number, but the list of these are quite available. But the antibiotics are given to a person, and the person is as important as the antibiotics. So what people do we have to be especially careful about? And with regards to people, the most important risk factor is age. You know, every disease has its magic old age. Old age, hold on to your seat, Del. Old age.
I'm not sure how to take that.
Old age, I'm older than this too. Old age for C. diff is 65. Above 65, you don't do as well with the disease as you do below 65. But then there are other diseases, so that patients with inflammatory bowel disease are at particular risk, have particularly severe disease, especially ulcerative colitis. Patients with chronic kidney disease, at particular risk, take longer to get rid of the disease. Patients with chronic liver disease. Patients who are immunosuppressed, either by drug, such as immunosuppressive agents, biologic agents, prednisone, which also increases the mortality of the disease. You can have patients who have diseases that make them immunosuppressed. Diabetes, HIV, organ transplantation. So those are the people, and those are the antibiotics that make the risk.
But let me just be clear. Are you saying that over 65, you get C. diff more often? Or over 65, when you get it, you do worse?
I think that probably both of those are true.
I was afraid you were going to say that.
You get it more often, and as a group, you do well. You don't fight the infection as well. Your white cells don't fight the infection as well. They can't kill the bacteria as well, and
if you look at the population incidence rates stratified by age for C. diff infection, and you see the rates in the highest age bracket, so these are adults who are over 75 or 80 years old, compare them to the people who are in the lowest age bracket, people in their 20s, the rates are 100-fold different. So patients who are older get C. diff more, and they do a lot worse when they've gotten C. diff.
You know, it occurs to me, listening to you list these things, that the one common thread is immunoincompetence or immunodepression. Diabetes, liver disease, chronic kidney disease, growing older, your immune system doesn't work as well. All of these things seem to correlate to decreased immunocompetence.
Well, I think we can almost step back and say, what are the fundamental things you absolutely need to get C. diff? And there's two things. You need exposure to the organism. If you're never exposed to the organism, you can't possibly get it. And then you need to have some fundamental problem in the host microbiome. If the gut is normal, if the bacteria in the host gut are able to resist the expansion of C. diff, you won't get C. diff. So all these risk factors that Larry's been talking about really are things that fundamentally impact the health of the normal gut microbiome. Immunosuppression, old age, perhaps along with all the other problems of old age, a less resilient microbiome. So those key things are what facilitates the development of C. diff.
I think that's an important point, but I don't think that's been proven. It's a very good postulate, and we're talking about the microbiota and the intestinal microbiota for almost every disease that we can mention today. But careful studies of the microbiota in different situations of disease is only now being started. And although what you're saying I believe to be true, I don't think it's really been proven to be that type.
Well, I think there is some direct, more direct evidence. There have been some observations that correlated the ability to mount immune responses to the toxin and showed that it may be associated with higher risk of developing C. diff in other circumstances, with having a recurrence, and more recent data from a clinical trial actually showed that people who had lower antibody levels were more associated with development of C. diff and recurrence. And we know that with age, you are less likely to develop an antibody response. And this is a very practical aspect of C. diff, because as we move forward, we're going to see immune type of solutions or possible solutions for C. diff, whether in terms of passive immunity or active immunity, such as vaccines.
And we're going to talk about that too. But I don't want to let this topic go by, which is the traditional risk factors here, without bringing up two additional classes of drugs. Everybody thinks antibiotics, right? But then we've got the proton pump inhibitors and the histamine 2 blockers. And if you're on those drugs, you're more susceptible to C. diff.
Yeah.
How does that work?
So there have been a lot of epidemiologic studies linking proton pump inhibitors, PPIs, and other acid suppression medications with C. diff infection. These are observational studies, so this isn't the best quality data. We did a study where we gave PPIs to healthy volunteers. We checked their stool before and afterwards. And what we found is that PPIs didn't act like antibiotics. They didn't wipe out the gut microbiome. They changed the gut microbiome just a little bit. They did decrease some non-C. diff Clostridial species, so perhaps organisms that are competing with C. diff for the same resources. But probably it explains why PPIs are a modest risk factor for C. diff infection. I don't think that that they're sort of at the level of antibiotics, and the epidemiologic studies bear that out.
We think most people get C. diff by ingesting spores, and spores are highly resistant to acid. You don't need to neutralize the acid for a spore to get through your stomach. So
I'm confused again.
So I
Poor old
think
naive me.
the PPIs do have, as Dan said, antimicrobial activity. They are Helicobacter drugs with MICs, minimum inhibitory concentrations for Helicobacter. And it wouldn't be surprising at all that they would also affect part of your microbiota, which you were able to document.
Well, you know, or it's possible, but not proven, that they have other more subtle effects. Earlier, Eric mentioned the bile acids as an important determinant of how well C. diff germinates, how well it goes from the spore form to the vegetative form. So it's possible, but definitely not proven, that PPIs may act at that step or another step.